The bulk of my presentation will actually be on prevention. And just curiously in this group, how many of us have received the Shingrix vaccine? Many of you are too young, I'm sure, but you know, it looks like 3 out of this pool of people, 4. Okay, so we've got some work to do. All right. Okay, so this is a very, very preventable condition. This is a patient of mine who I saw just a few months ago. So it's a 68-year-old businessman. And please note the typical conditions, stacked comorbidities that he had, okay, diabetes, dyslipidemia, and so on. So he presented with acute pain over his left forehead. He had a headache and he developed this blisteriform eruption. His left eyelid then started to swell. He had blurring of vision. And he was diagnosed to have zoster, but it was complicated by ophthalmicus, which meant that his eye and vision was in danger. And it was complicated also by infection, which we call preseptal cellulitis. And he had acute neuritis, which went on to a condition called post-herpetic neuralgia subsequently. And his treatment required not only admission, which disrupted his business plans, he had to travel overseas and all that, but also it required a multidisciplinary team, including an ID physician, an ophthalmologist, the pain anesthesiologist, and so on. So it's very disruptive, not only the fact that you need to break your trip and get all these resources utilized in this way, your hard-earned money going into the hospital, but also the fact that you could potentially have ended up being blind. So I think we have roles, as many of us in healthcare, primary prevention, to discuss with our patients and also our colleagues that 99.5% of adults for more than 50 years of age are infected with varicella zoster virus and are at risk of for shingles. So what is this shingles story all about? Well, if you see the varicella over here, there's chickenpox. Once you have the primary control of the infection, there is latency because the virus never dies in the dorsal root ganglion. And with reduced immune control, you have virus reactivation leading to the typical manifestations of zoster. So the statistics is that about 1 in 3 persons will develop shingles in their lifetime. And the incidence rates are similar, more or less, between countries with an overall rate of about 5 per 1,000 person years in Asia. And here locally in Singapore, there are an estimated 30,000 new cases of shingles on an annual basis. So it can be a painful and debilitating condition, and also it can have serious and long-lasting complications. So it starts off with a prodrome with headache, fever, and myalgia, and so on. So very often people mistake that for some other condition, and even clinicians may mistake it at that point for conditions like maybe acute appendicitis or something else. And then it can lead to an acute phase where you have that unilateral vesicular rash associated with that acute neuritis pain. And that's when the complication of herpes zoster ophthalmicus may or may not happen. And about 30% of patients can go on to a chronic phase, which can be several months to several years. And post-herpetic neuralgia is the typical manifestations at this point, where it's more than 3 months of that pain. It can be stabbing, it can be burning, it can be all kinds. And there is unfortunately a recurrence rate of about 5%. And the risk of recurrence is, those are the risk factors, okay? If you're aged more than 50 and you have the post-herpetic neuralgia pain that's more than 30 days, all right? If you're immunocompromised and if you are female. And the mean time between the first and the recurrent zoster is shorter for those who are 45 to 54 years, which is about 2 years. And about 3 years for those who are more than 55 years. So the recurrence is lower in the first 12 months after the onset of zoster. So this becomes relevant when we engage discussions with patients who say, can I get the vaccine after getting zoster? You can wait up to a year. So the complications that we talk about is not only the post-herpetic neuralgia, there are other neurological conditions as well, which includes aseptic meningitis, encephalitis, myelitis, Guillain-Barré, and so on. And herpes zoster ophthalmicus we touched on, but there's also the dreaded complications of stroke, transient ischemic attack, myocardial infarction, and cardiovascular disease. So although here it's about 1% of patients, but if you look at the burden of the disease, it's not a small situation. I'll show you some more data in that in a minute. So approximately 10% of patients with herpes zoster who are aged more than 50 can experience more than one of these non-post-herpetic neuralgia complication. So this is, forgive me, the slide is a bit slanted, but this is to show how herpes zoster is associated with myocardial infarction and stroke. On the left, you can see the data, showing stroke here and myocardial infarction, all skewed towards the association with zoster. And here, you can see how zoster can potentially be implicated either directly with a prothrombotic antibody condition, or with the formation of immune complexes leading to an inflammatory pathology in the vasculature, which leads to stroke or myocardial infarction, or via some other mechanism, maybe vascular remodeling and a vasculopathy syndrome. So this kind of association is something that we would like to convey to the public so that they're informed about this risk, because people don't know that herpes zoster is associated with stroke. And when we talk about the risk factors for herpes zoster in the first place, I think many of us are familiar. The older you are, the more immunocompromised you are. But family history is also important. If you have a family history, mother, dad, somebody who has zoster, you are at risk, okay? The data tells you that. Family history, age, and immunosuppression aside, the others includes chronic diseases. And so what are they? Can't you see the font size is small for you here, but it's like a whole load here. So diabetes, asthma, chronic renal disease, inflammatory bowel conditions, cardiovascular disease, chronic obstructive pulmonary disease, and so on. And of course, if you have stacked comorbidities like my patient that I showed you, then it's going to be, a bigger risk. Depression, okay, and also physical trauma, interesting, right? So that actually has been associated with cranial zoster. So quite a few patients who manifest with that have had some kind of precedent trauma of some sort. So there is this incidence of zoster and post-herpetic neuralgia, which increases with age. And this is kind of like a universal phenomenon. You can see the graph on the left showing you that many parts of the world report the same. This incidence rate as a function of age, when you hit 50 and above, suddenly there is an exponential rise in your risk, okay? And the same holds true for post-herpetic neuralgia. So why do these things happen? Well, there is this age-related immune senescence, your decline in immunity, which also appears with immunocompromising conditions. So the varicella-specific primary infection induces a VZV-specific cellular immunity, which is maintained subsequently with perhaps periodic boosting from VZV exposure or silent reactivation from latency. But later on, because of immune depression or because of age, you have got this cellular immunity which is declining, and that then leads to the manifestation, increased risk of the reactivation and manifestations of zoster. I just wanted to allude to various immunocompromising conditions. I don't have the latitude and time for that, but just to tell you about the risk of zoster in patients with rheumatoid arthritis who are receiving treatments, okay? Because there is a skew towards those who are receiving JAK inhibitors. So in this data, for example, you can see, displayed the therapies on your left, and you can see the risk that is quite obvious for JAK inhibitors. So very important when such individuals are going to be started on such therapies that they have a discussion with their provider in terms of their risk and whether they should actually get the vaccination before. I think more and more rheumatologists and other care providers like, those who manage inflammatory bowel diseases, and so they actually engage the patients in this whole narrative of prevention, especially with VZV vaccinations, because it is in some of their guidelines as well. So in a nutshell, the current treatment for zoster is suboptimal, and I want to set this as a segue for talking about preventative strategies, because our treatment for acute zoster is really humbugged by the fact that a lot of patients don't really know what they have. They don't know, and they tend to be dismissive of it until it becomes a huge agenda, then they come. And sad to say, but a lot of clinicians also will not be able to recognize this. And I think you and I know we share the same situation. So there can sometimes be iffy areas, but sometimes it's just, So it's very hard to get that treatment within the 72-hour framework to try to mitigate on collaterals. And the management of this acute neuritis, let alone the post-herpetic neuralgia pain, is quite difficult. And there's a lot of patient dissatisfaction because it's not easy to control the pain. You have to be on perhaps a combination of therapies and so on and so forth. A lot of events that could lead to even depression. So in regards to prevention of zoster, I'm not going to spend too much time talking about the zoster vaccine, the live vaccine, which was the one that we had before. It was available since 2006 because of its limited efficacy, especially amongst vulnerable age groups, and its decline in effectiveness over time. Plus the fact that being a live vaccine is contraindicated in immunocompromised patients who actually would benefit from this a lot. So since 2017, there's been the recombinant zoster vaccine, or RZV, but of course that's in the US, and it trickled, and finally we got it to these parts of the world more recently. So what is the RZV? Well, it actually is a recombinant vaccine. So there's an antigen, which is a glycoprotein E, and then you have this adjuvant system, which is ASO1B. So there's a liposome, there is a lipopolysaccharide, and a saponin together. So what do these do? Well, the ASO1B induces an early and transient activation of the innate immune response. And this early and transient response is often associated with local and systemic symptoms, which is one of the side effects, which I'll come to in a minute, but is followed by a very high and durable VZV specific response. And this is kind of prevailing for quite a number of years. So I will just share the RZV phase 3 program. So this was a randomized placebo-controlled multinational study, and the primary outcomes was to look at the efficacy for herpes zoster prevention in patients who are more than 50 years of age, and that's the ZOE 50. And for those who are more than 70, it's called the ZOE 70. 2 doses that were administered at least 2 months apart. So if you look at the chart on the left, you can see that across all age groups for ZOE 50 and the pooled ZOE 50 and 70, you can see that the efficacy was well over 90%. All right, so very, very convincing, and the efficacy up to 4 years post-vaccination was still very, very high. And if you look at the, if you look at post-herpetic neuralgia, this is the vaccine efficacy from both ZOE 50 and 70, and again, most of it above 80% to 90%, and also against the non-post-herpetic neuralgia complications as well, in excess of 90%. Very, very effective vaccine. So this is the problem with the adjuvant, the ASO1B, because there is this grade 3 or more adverse events post-vaccination, and you can see from here fatigue, fever, headache, myalgia, all of it in the range of about 30 or 40% of patients. Some reports higher post-marketing, but I think when we engage discussions with our patients, we tell them the side effects are mild. We don't see anything serious, but it can be potentially debilitating in the first 1 to 3 days. So try to kind of get that lifestyle of yours organized around that, so that when you get the vaccine, you have the latitude to chill, relax, and not be too involved in overseas or local activities. So this is an extension of the ZOE 50 and 70. It's a complicated chart, but just to let you know that they took on a further evaluation after a 1-year hiatus, and it began in 2016, and it continues until June of 2023. And during the 4 years of follow-up as the extension, so they also had subsets where they looked at the immune response and T cell and B cell response as well. So this is very simply put, this is the ZOE 50 and 70 here. This is not actually moving very well, but I think you can see that that is years 1 to 4 of the original study in excess of 90% efficacy. And when it is looked at the years 6 to 10, you can still see that the vaccine efficacy is pretty good. So this is a vaccine which, there's no need for a booster, for example, at least at this point in time. And the cell-mediated immune response is seen here as well, where the median frequency of the T cell response for the glycoprotein E specific CD4 persisted at more than 6-fold above the pre-vaccination titers to up to 10 years after vaccination. And I didn't show you the slide here, but the same was true for the humoral immunity as well. We also have data for immunocompromised patients to some extent in the same context of humoral and T-cell mediated immunity. But of course, when we talk about immunocompromised patients, and I don't have the time to show you a lot of data, but this is looking at patients with blood cancers, so that is HM below, where you can see that the vaccine efficacy as compared with placebo was about 87%, which is not bad. But if you look at the hematopoietic stem cell but autologous transplant, the vaccine efficacy is about 68%. So, we do have this, across the immunocompromised population. It works and it's indicated for immunocompromised patients as well. But this is kind of where, how we say immunocompromised is not one size fits all. It's a spectrum of conditions. So we can't really say with conviction what the efficacy will truly be in this group. So I think I'm good on time. And so these are my take-home messages. Well, herpes zoster is a clear and present danger, folks. Those 50 and above, please try to remember that there are serious complications, especially the debilitating post-herpetic, neuralgia, but also other things like ophthalmicus. And the last thing you want when you want to enjoy your wonderful holiday at the end of the year is to get herpes zoster, least of all when it's ophthalmicus. Remember the risk factors. Family history is often forgotten, okay? When you get older, when you have immunocompromising conditions and you have stacked comorbidities. The treatment is not optimal. At this point in time, we are struggling with treatment, very often under-recognized, and late treatments is not really going to help our patients. And there is this vaccine, which is commercially known as Shingrix, but RZV. So recombinant vaccine, I think that the live vaccine is not available in most centers here in Singapore, and I think it's already not available in the US since 2020. It's got a more than 90% efficacy against herpes zoster across all age groups. It reduces the risk of post-herpetic neuralgia as well as the non-PHN complications. It's indicated for those who are 50 and above, and for all those who are age 19 and above with an immunocompromising condition or who are going to have an immunocompromising condition. The efficacy has been maintained with data up to 10 years. Remember, there are 2 doses given in an interval of 2 to 6 months, but we can bring forward that interval if one is immunocompromising and might end up having to receive some immunocompromising therapy ahead of time. The transient side effects can potentially be debilitating to individuals. Our narrative really is to discuss this with the patients so that they are not going to get surprised by it. And there are some unmet needs in the context of understanding really the efficacy in the immunocompromised groups. Okay, with that, I thank you so much for your kind attention.
Thank you.
Happy to take questions.
So anyone here wants to ask a question, but online there's a question. Is it possible, do you think, to eliminate the dormant virus with a vaccine and antivirals, or is that just beyond our reach at the moment?
Yeah, thank you for that question. I don't think we can eliminate it really. I think it's rooted to export. We can try all these prevention measures, but I think that's not, anything within this generation, I don't think. Yeah. Herpes viruses are difficult to eliminate. Yeah, thank you.
So, microphone down the front. Professor Smith.
Thank you. It was great. Can I ask you, because we've had a vaccine program which offered the live vaccine up until recently.
Yep. Until 2 days ago.
Yeah.
Oh.
Yeah. And now it's switched over to the recombinant vaccine, but which is meant to have 2 doses. But if a person's been recently had the live vaccine, is there data on whether they still require 2 doses of the recombinant vaccine, or is that?
Yeah, so thank you for that. So there is actually data for if it's more than 5 years after the live vaccine, there is efficacy data for the 2 doses of the recombinant vaccine. Any data that is within that time frame, it's not supported by data. But we don't have any reason to believe that's going to be a problem. So the US CDC, for example, it states that, if that were to happen, their recommendation is wait at least 8 weeks. And you can go ahead with recombinant vaccine.
And a 2 dose.
Yeah.
Always.
And 2 doses. Yeah, and 2 doses.
Okay.
Yeah.
Yep. Even if you get the side effects first time.
Yeah, yeah. Well, the live vaccine, I don't think carries as much of the side effects as Yeah, the recombinant one. Yeah, I took the recombinant one. I can tell you, I was really tired for 24 hours. I wanted to curl up in bed and sleep, and I had to work, and it was not easy. You can still work, but you don't have the mojo. You feel like lying down and sleeping off. But it is what it is. So you have to tell your patients and surgeons, and then other people who have to deal with heavy machinery. They're not going to like you. So we tell them, clear your weekend and have relaxing time and get the vaccine.
Yeah. Thank you.
Thank you.